Very good evening. First of all, I would like to congratulate Kota Division Ophthalmological Society, President Dr. DrSureshKPandey sir, Secretary Dr. Rajan Chandel sir, and all the executive members for organizing CMH every month. The KDOS team is doing an excellent job by giving the platform to share the knowledge and the pearl of wisdom. Unfortunately, today's chief guest, Dr. Lakshman Singh Jhala sir, was unable to join us, and my congratulations to Team Care Group India for organizing this first CME in Kota. I think this is the first CME.
Yes, sir.
So last 2 decades. So congratulations, Team Care Group India. So today I am going to talk about the pearls for Toric Phakic lens implantation. As we know that the Phakic lens implantation remains an important part of the refractive surgery spectrum. Once we talk about the refractive surgery can be divided into 3 major groups. Cornea based, which includes the famous RK. एक जमाना था जब डॉक्टर पीएस हार्डिया सर ने पूरी ऑप्थेल्मोलॉजी का नाम पूरे इंडिया में रोशन कर दिया था. इंदौर was the city who became famous because of RK. He did the maximum number of the RK in the world, and there is a Guinness Book of World Record in his name also. So the cornea-based refractive surgery includes RK, PRK, LASIK, EP-LASIK, LASIK, conductive radioplasty, corneal inlay and rings. And then comes the era for lenticular-based refractive surgery, which include the clear lens extraction, what is known as the refractive lens exchange, and the Phakic lens remains one of the most important aspect of the correction of high myopia. There are different types of Phakic lens, anti-chamber Phakic lens, posterior chamber Phakic lens, but now we are mostly using the posterior chamber Phakic lens. And then the technique of bioptics, which includes the combination of the refractive surgery, LASIK and the Phakic lens. So the Phakic lens is challenging because most of these cases are young patients. They have very high expectations, and sometimes the surgeons, especially the beginner surgeons, are scared to start the Phakic lens because of inability to manage the complication. Sometimes in the beginning of the practice, we lack the equipment for pre-operative evaluation, which include the corneal topography such as pentacam, optical biometry, etc., etc. And of course, there is a fear of starting something new is always there. So these are the 2 videos which I am going to share with you of Phakic lens implantation. So I have opportunity to implant and to use the Phakic lens from all Indian companies, which include the Care Group India, which is my first and most preferred Phakic lens. And then I had chance to use the acrylic Phakic lens from Biotech, and also the Phakic lens from the Ophthalmology group. So here you can see the first acrylic Phakic lens implantation which I did few years back. And once the Phakic lens was started from Care Group India, I clearly remember that many surgeons were skeptical to use the Phakic lens because they were telling me, I discussed with them that it will be difficult to explant if there is a indication to do it. So I had shown the video of explantation of the Phakic lens, which was possible in like 3-minute incision without any problem. So once you start the Phakic lens, the beautiful part of the Phakic lens implantation is that it is a reversible surgery. It is reversible. You can explant it and you can change it if there is undersize issue, or if there is some other issue, then you can explant and you can work to address that issue. So the most preferred Phakic lens and the most
and in this video we describe the pearls for implantation
the most preferred lens is the Phakic lens, which is known as ICL or implantable columnar lens. This is the most commonly implanted lens from Star Surgical globally. And before, when we started the ICL, then we used to do the dark laser PI. Then that time you need to do a learning curve, and this is the advantage where the Toric IPCL or Phakic lens from KDOS India score high, because you can simply load it. There is no learning curve. Also, they provide the backup lens with the one lens. So if something goes wrong with the one lens, then you can always rely on the backup lens. Thirdly, you need not to do the axis marking, reference marking is enough. In this case, I am planting the Toric ICL, and you can see the lens is being planted using 3.2 mm incision. You can use 2.8 mm incision to implant the Phakic lens from KDOS India. So this is the tucking of the lens haptic behind the iris, so you can see the tucking of the lens haptic. And this is the video which I have done, I think 12 or 13 years. Manmohan Singh Jhala sir, who is a renowned ophthalmic surgeon from Udaipur. So the topic of the talk is the achieving perfect visual outcomes with the premium lenses. So it's very nicely elaborated by Dr. Sanjay Gupta, Dr. Arnav Sarovaya, my previous speakers, about how to achieve the perfect outcome in premium lenses. So in this talk, I will be very quick to deliver the journey, the optics, the lens, lendoscope, the selection, the execution, the counseling, pitfalls and rescue. So as we know that a premium lens is not a product for sale. It is a promise management procedure. It's a trust building procedure. Patient comes with a lot of expectation, a lot of trust to us, and we have to deliver that trust while doing the surgery. So before I start my talk, I'm going to show you a video of TriDiff lens implantation. Dr. Sanjay very nicely shared the video, and this is a case 38-year-old lawyer who came to us, and this was the first case where we did the TriDiff lens implantation using the Zepto nanopulse technology. So this was a young lawyer, and he was very keen for getting the perfect lens with minimal or no dependence on the glasses. So the surgery was done under topical anesthesia. Here we used the Zepto nanopulse technology to perform the capsulorhexis. As we know that the capsulorhexis in these cases is difficult because of the associated positive interventricular pressure. Once you start the rhexis, then the capsulorhexis or the capsule may run away, and this is known as Argentinian flag sign. So once the capsulorhexis is not perfect, then your plan to implant the premium lens such as the EDOF lens or multifocal or trifocal lens or toric lens can be in trouble. So this device, which is Zepto nanopulse technology, can be helpful to achieve the perfect capsulorhexis in cases of white intumescent cataract. So you can see this is the device with the silicone cup being inserted using 2.8 mm incision, and once you use the vacuum with the nitinol ring, this achieve perfect capsulorhexis within few seconds. So you can see this is perfect capsulorhexis, no ragged margin, no tags, and this is the capsulorhexis opening. You can see the capsular flap, perfect 0.25 mm size of rhexis. And once you perform the capsulorhexis, then the surgery is not difficult. As you can see, this is the intumescent cataract, and this can be aspirated quickly with the phaco, and then we are implanting the TriDiff IOL from the KDOS India, and this is a well-centered capsulorhexis. This is the TriDiff lens, and once we implanted the TriDiff lens of 20 diopter, the visual outcome was perfect. The patient regained 6x6 and 5 vision without glasses. So this lens is a plate design, hydrophobic acrylic material, and you can see the rings, and the loading of the lens is straightforward and simple, and this is the loading of the lens into the capsular bag and implantation into the capsular bag. you can use the technique such as hydro implantation, but I prefer to use under the viscoelastic to avoid any problem. So once you remove you implant the lens, then you can remove the viscoelastic behind the lens, and you can see the lens is well centered. I prefer to use the triamcinolone and intracameral moxifloxacin, and you can see this is the perfect surgery and with perfect visual outcome, and the patient was able to read the need paper next day after surgery. So if we talk about the journey of the cataract surgery, we have read about the couching, the first IOL, then phaco foldable, and now we are living in the era of trifocal, EDOF, and the other premium lenses, toric trifocal, toric EDOF, etc. And during that time, patient used to come to doctor, doctor साहब surgery करवा कर दो, मेरा cataract निकाल दो. Now the time is changed. Dr. Anna very nicely mentioned that, doctor, can I drive, use mobile phone and live without glasses. Now patients are very demanding, and tomorrow, like next after 10 years, the patient will come. Will my vision feel natural even in every lighting condition? So this will be the future. So what do you mean by the perfect visual outcome? There should be optical clarity, there should be visual quality, functional freedom, emotional satisfaction, and surgeon safety. So the best trifocal results begins long before even the first incision. And if you talk about the trifocal or multifocal or bifocal or monofocal lenses, EDOF lenses, a premium lens does not give the three perfect images. Trifocal lens, it gives three useful opportunities for the brain. And trifocal lenses can help us to deliver the far, intermediate and near good vision. And there is energy distribution. Light for trifocal lens, light is the currency and spend it wisely. So this is the common saying for trifocal lenses. So once we compare the trifocal versus EDOF lenses, the best IOL is not the newest IOL. It is the IOL that best matches the patient compromise. So counseling is a very important, assessment of the patient personality is very important, and we should always try to assess the personality, the need of the patient, then select the trifocal lens. And we have so many lenses available: Panoptics, Fine Vision, Tridip, Triphobic from KDOS, AT Legia, Ray 1 trifocal from Rayner, and Synergy from J&J. And now Synergy is discontinued. And so this table shows the differentiation between the lenses. In order to save the time, I'm not going to go into detail. So you can see now question comes, how I choose the trifocal lens. So it's very important that once we choose the trifocal lenses, we should always do the proper assessment of the patient, care reading, the counseling, and then choose the trifocal lenses. So KDOS India, we had trifocal lens, Triphobic HD, which is true trifocal hydrophobic micro-incision lens, which provides us full range of vision correction, provide far, near, intermediate vision. It has balanced distribution of light, provides better contrast sensitivity, and spherical aberration correction is sensitive to 0. This is pupil-independent trifocal lens, which provide high quality vision in all lighting conditions. Synchronized cast molded lens. This is the synchronized cast molded lens, and you can see the trifocal lens. Optic is body biconvex, and optic design is modified refractive spheric optic. The material is hydrophobic, and the A constant is 11.9.0. Refractive index is 1.53, which allows us to manufacture and deliver the lens through the small incision. Haptic angulation is 0, and the optical power near it is 3 plus 3.5 diopter, and intermediate it is plus 1.80. And this has 4.2 millimeter refractive surface, and it is available into the disposable delivery system. And you can see the near end is plus 3.5 and intermediate end is 1.8. The triphobic IOL is pupil independent IOL, which is useful to provide excellent far, near and intermediate vision. Light is distributed to intermediate, near and distant focal points, retaining the high quality near and intermediate vision in mesopic and scotopic conditions. And as we all know that multifocal trifocal lenses are they have potential for creating glare and halos. So it's important to explain about the glare and halos to the patient before doing surgery. However, the trifocal lens, with the superior patented optical design, it minimizes chances of loss of light, resulting in very low incidence of halogen glare. And you can see the molecular transfer function, the contrast sensitivity, the distribution of light, and the defocus curve, and the dynamic energy transfer. With the dynamic energy transfer, it transfers 50% energy distributed for distance, 30% for near, and 20% for the intermediate. So the modular transfer function is measurement of contrast sensitivity for any optical surface, and the most interesting part of the trifocal HD trifocal lens is the actual IOL power. You can see the trifocal box, it provides the actual lens power. Here it's saying 22 diopter, but the actual lens power is labeled as 22.20 diopter. So this is the very unique aspect about this lens design. So patient selection is very important. The ideal trifocal candidates are the patient, those who have healthy optic nerve, retina, etc., regular cornea, good tear film, and also with 0.75 diopter corneal astigmatism. One of the most important causes to have poor satisfaction is the residual corneal astigmatism. And the cases which are not suitable for trifocal lenses are macular disease, irregular cornea, severe dry eye, glaucoma, optic neuropathy, journal weakness, and rigid perfectionist personality. So it's important that we should always do the thorough evaluation, especially the tear film. The tear film is the first premium lens surface. I have written trifocal, but this is applicable for all premium lenses. So always treat the tear film very carefully. Treat the dry eye, control MGD, medium gland film dysfunction. Repeat the measurement. If there is a fluctuation of the K reading, do not implant the premium lens optics in a case with the dry eye or poor tear film. And remember, the dry eye can mimic the lens failure. It's very important that if there is a variation in the K reading or keratometry reading, always try to treat the dry eye first. Repeat the K reading until the K reading is consistent, and use 2 or 3 equipment to take the K reading. So it's very important aspect for any success in the premium lens. And nowadays macular OCT is very important, because sometimes subtle ERM, early AMD, vitreomacular traction, diabetic macular changes, old CR can reduce, CSR can reduce the contrast, and in premium lenses this can be important concern. So it's always advisable to take good OCT, specular microscopy, etc., and always use the optical biometer for lens power calculation. So the target, the astigmatism is the commonest enemy of the crisp vision of trifocal in trifocal lenses. So aim for less than 0.5 diopter astigmatism. If you have more astigmatism, then you can use the Toric model, or always use your incision at the tip axis. So in the OR, aim for the perfect surgery, capsular axis, cortex removal, IOL implantation, and most important thing is aim for the central axis, and ensure that there is 360-degree capsular optic overlay, because trifocal lenses are not forgiving lenses compared to EDOF lenses. So therefore centration is very important. And before surgery, treat the ocular surface during surgery, remove the viscoelastic, avoid any rotation, and after surgery check the rotation in case of trifocal toric lenses. And trifocal lenses are more sensitive for PCO or posterior capsule technique. So if there is a significant PCO, then you can do the YAG laser before ruling out the residual refractive error, dry eye, or IOL decentration, or need for exchange. So always you rule out these factors, so that if you require IOL exchange, then don't do the YAG capsule roaming. And counseling is very important. And the 4A for counseling is assess the lifestyle, assess the work, assess reading, assess the mobile phone use, driving, and expectation. Number 2A is ask what is the distance matter, most, what would disappoint them. Third is align. Explain the spectacle independence, halos, and neuroadaptation. And 4 is agree. There should be shared decision with the patient, documented, and informed consent should be taken. So So this is the how to convince the patient for trifocal lenses without overselling. So this slide talk about the patient who is honestly counseled for gives halos, the patient who is surprised by halos loses the trust. So trust is very important. Always ensure that the patient have full confidence and trust with the surgeon even after surgery. So the checklist is there mentioned here. The expectation management is the most powerful premium IR technology. We need to manage the expectation, and always in order to avoid the pitfalls, we should just keep in mind refractive surprise can be avoided by careful biometry. As cylinder can be avoided by making the incision on the strip axis, and poor counseling should not be done. Never ever do over promise to the patient. Always do under promise and over deliver. And in order to manage the glare halos and starburst, do not deny. Explain them. There can be glare halos which will be less after neurodepression after 6 months to 1 year. And there are 4 P's of the unsatisfied for managing unsatisfied trifocal patient. One is the first piece is the ocular surface, which is dry eye, MGD. The second P is power, the third P is position, and fourth P is perception. The unhappy patient is not a failure, he or she is a protocol. So final take home message, the 10 most important pearls for success of any premium lens includes: the first is patient selection, select the patient before selecting the lens. Then second is treat the surface before like in measuring the eye, before doing the ocular biometry. Always screen the macula and cornea. Specular microscopy is important, topography is important, and OCT is important. Aim for plano and residual astigmatism must be less than 0.5 diopter. And use trifold toric if the cylinder is more than 0.75 diopter. Center the axis and optic meticulously, counsel the patient before halos, before they become the complaint, and allow neuroadaptation explain about neuroadaptation. The YAG laser should be done after the diagnosis is clear. Never be in hurry to do YAG laser. If the patient requires IOL exchange, then wait for before doing YAG laser. And audit your outcomes and improve your constants. So this is the take-home message for getting the perfect visual outcome after trifocal or any premium lens implantation. Thank you very much for your attention.